Good evening and welcome to AMDA COVID Grand Rounds, Pearls from your colleagues, and ongoing peer discussions on COVID-19 in the post-acute and long-term care space. I'm Sabine von Price-Friedman, your host from the Washington State AMDA chapter. What could be worse for our vulnerable patients in SNFs and other long-term care settings than the COVID pandemic? The answer for many of us working in these settings is unfortunately obvious: the twindemic of COVID and influenza. The good news is that we know that non-pharmacologic interventions such as cohorting and masks and so on decrease transmission for both COVID and influenza. But as we have experienced to our peril in the big July COVID surge, as soon as we relax those, infections come roaring back. Additionally, weather will drive most of us back indoors, which may increase transmission rates as well. Us clinicians and medical directors are faced with the facts that COVID and influenza are clinically indistinguishable from each other, especially in the early stages. COVID and influenza co-infections can occur, and many of our originally COVID sick and recovered patients are now over 90 days out from their original diagnosis and are theoretically susceptible to reinfection with COVID. All these facts make for a complicated scenario and difficult yet to be sorted out infection control situation. And they highlight the absolute importance of suppressing the disease that we do have a vaccination for, influenza. Now more than ever, a successful influenza vaccination campaign for staff is paramount. We are so pleased to have a distinguished panel of peers that will share their efforts and successes implementing system-wide influenza vaccination campaigns and explore outbreak control in the COVID world. We're looking forward to what their experiences, roadblocks, and successes have been. We want to make this an interactive discussion and encourage you to use your chat function. Being engaged in this chat by all of you is a great opportunity for all of us to learn from each other. Make sure you chat to everyone if you want all of us to contribute. With us today, we're pleased to introduce Patrick Coate, PharmD and Director of Pharmacy Services at the Good Samaritan Society. Good Sam has impressed us all with their successful influenza vaccination campaign last year. Dr. Bob Resnick is well known to all of us for her incredible leadership in the field of aging. And she worked with GAPNA and the Gerontological Society of America on enhanced patient, family, and staff education on influenza. Dr. Resnick is also featured on a recent AMDA on the Go podcast on influenza vaccination, and you might want to listen to that as well. And finally, we have Dr. Susan Levy, last but not least, our AMDA past president. She has been a leader in implementing vaccination programs and outbreak control in her setting. Let's start with a poll. Erin, if you would pull up the first poll. Last year, what was your staff vaccination rate in your facility or company? You have several different choices: less than 50%, less than 70%, between 70 and 90, or more than 90%, or I don't know. Go ahead and submit your answer. And any answer is fine. And Erin will monitor this and give us a minute until we have our rates back. Wow. So first of all, I am so glad that only 5% said that I don't know. So I think that is just a real win, I think, for all of us that we are engaged in this process. And then it runs the whole gamut. The most people have over 90%, and that is really, really a fantastic improvement over, I would say, just about 5 years ago, where that would have been the absolute exception. So we do have tools, and we do have more knowledge on, we probably have a bit of a culture change even going on in the setting. Yet there's a number of us that have not been as successful. So about 35% have less than 70% a vaccination rate, probably associated with a higher risk of influenza illness in your facilities. So this is a great baseline, and hopefully next year, with the help of all of you, we will move that red line even above 50%. Well, why do we say above 70%? That would be a great, or 25% improvement or something. We'll do that poll again next year. So now we're going to do something that's called, I call that an open poll. So I'd like you to all look at your chat function, and I would really appreciate if you contribute to this poll and say, well, either what was your biggest barrier or your biggest contributor, or both, to success. So those of you who have over 90%, your biggest contributor or your biggest barrier for the other ones, or whatever you want to put in. And I'm monitoring the chat now. So we have Susan Gillespie saying influenza vaccine myths, so probably busting those myths. Staff claiming allergy to vaccines. I think that'd be a great one for Patrick to pick up. Staff feeling like the immunization is not effective. Oh, and here somebody had, Assad had strict guidelines and threat of losing employment. So this is certainly one approach. And then again, fears of a variety of myths. And here's a situation by Scott Chabot. And I think that's a situation that actually I am faced with this season. They had a requirement in New York to for those staff who don't get a flu shot to wear a mask. And we don't know how that's going to work out as a threat this year. Probably not, but that's okay. I think maybe all of those who have to wear masks all around now know the perils of an infectious disease. So thank you very much for all that input. And let's get to our first question. And I think, Patrick, I'd like to start with you. Tell us about Good Sam's influenza campaign, and what did you do differently last year?
So last year was the first year that we mandated flu vaccine for all employees. And the mandate was quite strong, and it did include all levels of employees, including those who did not come into contact with patients or residents. So just quickly, Good Sam is a large provider. We have 141 skilled nursing facilities, but we also have assisted living, HCBS, affordable housing, and then we have because of the sheer size, we have large corporate services, IT folks who work from our national campus, et cetera. And the mandate extended to every single employee in the organization. So that's what we did differently, and the results, I think, once you mandate something, you're going to most likely get the results. But we went from hovering around 60% vaccinated for our employees since 2017, hovering at just about the same number, maybe bumping it up a little from 50% in 2017 up to 62% in 2019. We went up to 98.7% last year vaccinated. So it was a successful effort. It wasn't easy. With follow-up questions, I could talk more about what I thought got us there. Beyond just the simple mandate. But that was the big thing we did differently last year.
Well, I think the first question that we may all have, and that's a question that I posed to myself and my CMO as CEO, was, did you lose employees? And how did employees react? And was there a threat of losing employees? And how did you deal with that?
So we certainly heard that threat, and I think it goes without saying to anyone in this audience, we were concerned about that. I'll tell a quick story from a recent call about COVID-19 vaccine with one of our regions. I presented to the region about what it looks like it's going to look like for the COVID-19 vaccine. And someone asked, will it be mandated like the flu vaccine? And I said, I'm not in a position to decide that, but I would expect that it would be, given our commitment to vaccination. And immediately someone said, well, everyone's going to quit then. And our regional vice president, who's not a clinician, and I think this displays a lot of the buy-in we have across our organization right now, it was great. I didn't have to even answer the question or address the concern. He spoke up quickly and said, remember, we had so many threats with flu vaccine, and this was for an entire region, so covering about 30 skilled nursing facilities. He said we only had one quit.
Oh, really?
But the noise and the threats of resigning were certainly there. But at the same time, I don't want to minimize that either, because I know the staffing challenges that our industry faces, that all of us face. It's certainly a concern, but we decided to go ahead even being fully aware of that concern.
Well, congratulations for that courage. I think that is fantastic. Did you have any trouble with the unions? Do you have unions?
So since I'm not aware of any problems with the unions, so I'm guessing that's because we probably don't have unionized labor in any of our locations. I'm not aware of that anyway.
So there is the mandate of everyone being vaccinated, and then there is a whole world probably of other action to operationalize and monitor and track. Tell us about your highlights there, and what challenges did you have, if any?
And this maybe, if I was in a position to give advice, probably my biggest piece of advice for folks out there who are with locations or with organizations where it just feels like mandating vaccine for everyone is not going to be doable. What we did for the 3 years prior to our vaccine mandate, we mandated reporting of your vaccination status. And so that gave us 3 years to work through the bugs in the system, because we knew we were led. I don't see her name on this call, but she's a longtime AMDA contributor and supporter. Dr. Vicki Walker was our chief medical officer, and she was the energy behind this work. And she knew, and we knew, that if we had holes in our process, we're an organization of 24,000 plus employees. If we had holes in our process, this could quickly fall apart, not only with people just ignoring the mandate, but also with potential for legal action, right? You have to be careful about mandating something for employee A and employee B getting away without doing it. So that was a big concern. And so we mandated reporting the vaccination, which actually bumped our rates up a little bit. We saw a 10 to 15% increase by mandating the reporting. But it got people sort of used to the idea, and it got over some of those initial hurdles of, well, I don't want to tell you what my vaccination status is. And we were able to sort of work with our legal team, work with others to say, this is fully acceptable, legally endorsed. This is a legally endorsed thing to be doing. We are allowed to ask these questions about your vaccination status. So we got over all of those hurdles before we actually went to the mandate. But building the tracking system was a critically important part of that. And really what my role in supporting Dr. Walker's leadership on this initiative was managing the data and using that data to chase down every last employee that hadn't reported. And we literally did that because we believed so much in this mandate, and we felt that if we didn't put every effort we could into it, that there would be many ways that it could fall apart.
Well, that is really impressive work, and it also shows you not only the breadth, but also the intensity and the focus that you had to show, basically chasing down every single employee. I think that is what it's actually, taking. But speaking of chasing down people, Dr. Resnick, let's talk about educating and educating staff, but also educating the patient's family, which of course is a big part of the world of influenza. Tell us about what you did and what impact it made.
So first of all, coming from a behavior change perspective, it's not any one thing. And I just want to reiterate what Patrick said. My facility, we've required immunizations for years now. We haven't lost anybody. We have had a few maskers, which I continue to get after on a regular basis. And Patrick, what you described, it sounded like you were a little bit the champion there, as well as the medical director. And I would say those are probably the two most important things. Make it law and have a champion, because it is hard to follow this stuff. Education is a useful component of behavior change, but it's really what people believe. And so it's finding out, and I think somebody in one of the chat messages talked about debunking myths. And this is critical, especially these days. Understanding things between flu and COVID is one thing, but just the information about immunizations, how they work, why they work, what works, what doesn't work, and all of that, and helping people believe that it really is useful, that they can't depend on herd immunity unless it's absolutely, positively everybody, and that's not likely to happen. And then I think I'm not sure if Patrick's going to address it, but some of the excuses that are not correct, and I think somebody may have raised that in the chat. So it's really thinking through.
Let's talk about some of those because we all experience them. So the egg allergy, right?
The egg allergy and lack of concern there, really, for the most part, unless you really get anaphylactic. I had a funny clinical story. There was a patient who claimed on his records he'd never had a flu shot. The family claimed he had egg allergies. The guy was eating eggs every morning. And I sort of brought that to everybody's attention. And he got a flu shot that year. So it's just what people think, and really our issues are quite different. And
what other myths have you seen, all of you? Susan, I'd like to hear from you too. What are the myths? I think the egg allergy is a big one.
Right. Yeah, it's going to make you sick, the usual things. And yet, even though we know we have science and research that says, listen, it's flu and cold season, there's a good chance you're going to get a cold shortly after you've had a flu shot, just because it's flu and cold season.
I think that is the biggest one that I see. Last time, I got it, and then I got sick.
Sick.
So that is.
They don't realize it's
egg allergy.
Right.
Yeah.
And I think that's another important, is that, most people, if you've had a bad bout of flu, you feel pretty bad. And so it is different than just the run-of-the-mill cold and upper respiratory infection. And you really, if you can do anything to avoid it, you certainly want to do that. So, I think that's one of the obstacles. I think, there also are concerns about vaccination side effects. For a while, there were concerns about, the preservatives and mercury and A number of things that actually have been debunked or that there's alternatives for. But, you have to be, as the medical director, and the practitioners in the building, I think you need to educate yourself. You need to be champions. And, you also can't tolerate practitioners in the building who maybe aren't supporting vaccinations. That's got to be really, really, really clear, that everyone on board has to really support this. I mean, it really does start, I think, as Patrick pointed out, it starts with leadership, and you really have to have that buy-in to start with, and commitment. And, it starts there. If everybody in leadership isn't willing to get their flu shot, that's one of the first things to do, in addition to tracking your reporting, is you've got to get everybody on board.
Yeah, Patrick, I really liked that the commitment was to everyone, even, I don't know, the people in IT or the pharmacists who maybe never, I think that is really important. And then the leadership that you mentioned, Dr. Vicky Walker, and she and I had lots of discussions about that. And I think that's really important. So my story is that I, as a CMO of Avalon, I had the experience that we had enormous financial losses one year through influenza. And the chairman of the company asked me, what can we do about it? And I said, well, we know what to do. It's get everybody immunized and get a whole system around that. And I said, will you give me the go ahead to mandate it? But we couldn't mandate it as a condition of employment, but we strongly suggested it, and we had a whole campaign around it. And that is what it took. A letter from him, signed by me, to the administrator, benefits to the administrator, and then local champions. But if it had not been for Randy Kitten, I don't think we would have in 2012 had the kind of results that we really wanted to see, which was also over 90%, not 98.7 though. That's really fantastic. So, Barb, are you, so the thing with, like, you get sick from flu, that is a huge, it's like I got that flu shot. How is education affecting behavior change or that myth busting? How is that?
So again, you're dealing beyond knowledge, you're dealing with people's beliefs. And I have one very favorite patient who, she insists the flu vaccine gave her arthritis. Every year I go through it. One of the most important things is to never stop asking and educating. Mm-hmm. Because we do have a tendency, oh, that person never gets a flu shot, just check them off. And you do have to keep after this, because after a while, somebody may understand that you believe in it enough, they'll come around, and you just have to be that champion. So again, it's just reiterating the simple facts. It's also really important to get through to somebody and differentiate what is really the motivating factor under this. Like, a lot of people might say, I don't have the time to get a flu shot, and we can laugh or whatever. It's making it very accessible, which usually for our staff and residents isn't too much a problem. But even if they have to walk down to the basement of the facility, that may be a barrier. So it's really finding out what it is that's stopping them. Many things may just be an excuse. So keep, it's formal training. You can do it in handouts, and you can do it one-on-one. Mm-hmm.
Yeah, very good. Susan, what did you do different last year, if anything, or what have you learned in your journey? I know you and I have been talking for years.
Right. Well, I will say that I still have one facility where I don't think, I'm not sure that we've made the commitment to make it happen. It's the leadership is like, well, some people just aren't going to do it. So until we make that change, we may not be able to hit those 90% figures. We're also in a state that does not allow you to mandate it as a term of employment, which, there are some public policy issues, but, and that has to do with concerns about staffing and employment and unions, all those issues that have been brought up. One of my other facilities, though, it's an expectation. And so they have much higher numbers. So I think that it just varies. They were in different organizations. I think that's part of what, what we have to deal with. So I do think, though, as practitioners, there are, if your organization will help support that. I mean, I think both for resident vaccination as well as employee vaccination, the requirement that there be documented education by the practitioner, just like they would in an office practice. I mean, you have that discussion with, with your patients. And I always talk about you want the 3 no's, the kind of sales pitch deal of, you don't stop with the 1 no, I'm not going to have it. You just kind of keep trying a different approach to get someone to agree or understand what it might take to get them to agree. And I think the same thing is for employees. I think probably requiring employees, and I think some of our members have done that, to actually meet with the medical director if they have a declination. Now, we are required in our state to get a declination from the employees. Yes. So that is something, and that gets into, making sure that gets tracked. But I think that's, setting an expectation that you have to be counseled. I mean, I think there's, other ways. You can try to make it competition. You can try to get peer pressure. There are other efforts to try to work even in the situation where you can't really mandate it or make it, or you can mandate it, but you can't make it a condition for employment. And that's really what is the biggest ability, is to make sure that your people have something on the line for it, which would be their job. It would make it a lot easier in some cases.
Yeah, I have a really interesting question from Asad Zaman. How do you overcome the historical mistrust in the government, particularly coming from the minority residents? And you could say government, but I think you could also say / traditional healthcare system. And that kind of ties into our last webinar. I think the medical system has failed our minority employees historically and presently. What is a good way to overcome that? And that question goes to all of you.
So I think that might be around some careful and repeated education about the benefits of the flu shot for them. I saw in the chat somebody raised, get a flu shot so you don't give it to your residents. But it's also, I think, a big thing in terms of giving it to families. Listen, we know this has been a big issue with regard to COVID. Nobody wants to bring it home, and nobody wants to bring the flu home. So that is, I think, a useful aspect for employees. I also say, it's free, it's easy, it doesn't get better than that. And so really thinking that through and working with them. It's repeated messaging. Sometimes, and within the National Adult Vaccine Program, I know we've done some work around this. It's also champion role models. So if you can find somebody within that community, I think that would be that's also helpful. So you're speaking, a peer-to-peer or whatever it is.
That's what I would think, that really the peer-to-peer, we don't know what maybe that cultural myth is, right, or what that cultural barrier is, because that is not our life experience. Right. And really it's about fighting for every last person. And really getting a peer-to-peer, I would think is the answer here if you can. Mm-hmm. How about you, Patrick? Do you have anything to add to that?
Yeah, I think in general, I was reminded, and hearing my colleagues here, it's so obvious that each of you handles these situations in the right way. But I'll admit, for me, it was there was a learning process to how we went about and how I personally went about myth busting or educating. It's easy to sit on on our high throne and say, of course that's stupid, and I think what we saw, and I'm thinking of a particular population that we worked very closely and very hard with, a very rural group of our employees, and it was about learning to have very respectful conversations that truly did, as soon as I opened my ears and truly listened, I understood a lot more about, and I think Barbara, your talk about the belief system, it's very easy to go into these conversations quickly and say, these are the myths, and so we're not even going to talk about those because they're myths, and if you were smart, you wouldn't be, you wouldn't worry about these things. And instead, I think we need to approach it from a different perspective that has a lot of mutual respect. And I'm not saying it's easy or progress is quick when you do that, but at least it frames it differently, and it made me feel better about myself as a caregiver and how I work with people too. So it had a mutual benefit.
Yeah, I would agree. I mean, I think there's the whole issue of, and we're not always experts at that, and we're not always trained in that, which is cultural competency, and being able to recognize how we need to appreciate differences based on what people come from, in terms of whether it's religious beliefs or cultural beliefs. And so, yeah, I mean, it's nice to say about the counseling, but the one-on-one counseling is your opportunity to really explore what the issues are. And you'll probably learn a lot about your employees and their backgrounds. And some of the points they raise are certainly are understandable. That doesn't mean we can't continue to try. I think the point that was raised about trying to find champions, from those areas that can help or assist, making sure that you're able to do that, obviously making sure that you do listen, and you're trying to be open, and you're trying to address what their concerns are. But I think those things are all, are all pretty critical. I mean, some of those same skills you have to have in your practice to be able to, educate patients and try to make them do the right things for their own health.
Well, thank you. I think that was really something that gave me pause. I've been doing this for a long time, and becoming culturally more aware, I think, is something that I certainly have tons of opportunity, and maybe the cultural high horse doesn't do it anymore. Not maybe, that's the cultural high horse doesn't work for starters. And it's not good practice from so many perspectives.
I would also throw in there that I think we need to be careful not to group cultures together, because not everybody within a culture is also going to, these are very personal decisions.
Make assumptions, right?
Everybody, you'll forgive me, but everybody's got their own mishigas about why they want.
What culture are you from?
Just take a guess. And so I think, I always worry about putting people into little cultural bubbles. Mm-hmm. Really look at it as well from an individual perspective. And, quite honestly, all you have to do is ask and tell me what stops you from getting immunized. Give me your rationale. And you may get my arthritis story. That's all I can tell you.
Mm-hmm, mm-hmm, mm-hmm. All right, let's pivot from this and from the immunization campaign to the vaccine. And I think the first question here goes again to Patrick, but it's to all of you. What vaccine are you recommending this year? Patrick.
So we do recommend the high dose. I think you want the general answer, but yeah, we recommend the high dose vaccine to those 65 and older, and regular dose for those younger.
And this year, I think we have a high dose quadrivalent, right?
Yes,
that we did not have last year, correct?
That's correct.
Yeah. And they are all recombinant, right? So they're not, which ones, is there any more egg-based out there? Patrick?
Well, there are still vaccines that are
Yeah.
produced in an egg medium, yes.
Okay.
And so our primary vaccines happen to be those, but we have a backup vaccine that's produced in an egg-free way as well.
Okay.
Yeah, I would say 2 options are egg-based and
Mhm.
1 not.
Mhm.
But
Oh, no.
that's the exciting part. There's lots of new options.
Yeah. So having the option available at least for non-egg based, and you could also have people go to a pharmacy if you don't have it. I mean, I think that's
You know, it didn't come up in our prior talk about encouraging vaccination, but you reminded me there it's important, I think, to keep making sure everyone's aware that essentially every health plan is required to cover flu vaccine.
oh yeah.
You know, no copay, no co-insurance, nothing. And yes, there may be some slim slivers of exceptions out there to that, but in general, you know, because some of our employees didn't want to get vaccinated with us, but they were more than happy to get vaccinated at their primary provider or at the pharmacy or wherever. And so I think that's an important little piece, is you can take cost almost completely out of the equation with this.
Which is certainly a nice development as well. Yeah, so I think there's really no discussion around the high dose for all those over 65 at this point. And I think the only thing that I want to mention here is that they're single dose, and you have to, they're all Med B, under Med B. And Patrick, please correct me if I'm wrong, but they're all under Med B reimbursable. So even if a patient's in a Med A stay, and you have an opportunity to do it, because you can then get reimbursed from, it doesn't fall under your daily rate, you get reimbursed. However, you have to set up a system for that. So the pharmacy will not collect. You need to collect as a organization, and that, as a medical director, that is an important reminder in your QAPI meeting. What is your system to get collections? And I know in my organization, we lagged behind on that and really lost money. In fact, you can make a little bit money because there is an administration fee. And that's something for the administrator to know. You know, if you need another motivation for the administrator, there is an administration fee that you can collect, and you have to collect yourself, or else you will be paying that high dose for sure. Or you're paying the other one too, but it's much more cost effective. All right. Anything else that you want to cover in the area of staff or resident vaccination? Is there any other comment that you would like to make?
I just have one brief comment, is that we work pretty closely with the manufacturer that produces our vaccine, and I'm hearing from them that, you know, orders are incredibly strong. And so I think providers should expect that there will be more demand. It may just be them firing on what the demand is going to be, but they're certainly anticipating that the demand is going to be high for flu vaccine this year. So I think on its own, with COVID as the backdrop, we should expect to see more people out there that want to get vaccinated.
Good.
Which is great.
That's good. That's great. The only other thing that I would like to say is we have, and there's a question about the length of how long the vaccine works. And that's been a question a lot in my organization too. I have pushed to get staff done first, usually the middle of September. If we had the vaccine available, to be completed by October, and then follow up with the residents to be vaccinated. And the reason is that part of the reason is, first of all, you got to get it done, and our staff are certainly, for us, the higher risk people. And then the other one is too, that you're not in the cold and flu season as much, so you don't get some of these concerns that raise their heads when you're still doing it in September. Some people, however, have said, well, you know, how long does it does the protection last? And then do we need to revaccinate? What's your take on that, Patrick? Or Barb, anybody.
I was just going to say the ACIP guidelines just came out. Patrick, you're nodding. And they recommend at this point to just try and get everybody vaccinated by the end of October. I don't believe there's recommendations for revaccination. Patrick, correct me if I'm forgetting. The one thing, and somebody asked me some questions about ACIP because they don't recommend any specific vaccine. They won't come out and say it. The bottom line is, you know, anything is better than nothing here. And I'm just thinking there may be some facilities out there that they won't pay for the higher dose. They're going to go straight up flu vaccine, and it's kind of any port in a storm, give whatever you can when you can do it. But there is a little concern about too early. Patrick, sorry, I didn't mean to jump in. But I was
sure. So, I mean, there is evidence that the impact does wane, but still the ACIP recommendations are what I would stand behind is that we have so many challenges to administering vaccine and getting people immunized that I think that overwhelms other concerns about the waning.
That's kind of where I'm at. I think my biggest thing is I want to get it done. And once people start getting sick from colds and then it's going to get harder for us. And you mentioned that facilities do not want to pay for the high dose. Just again, they don't have to if patients have Medicare. And now over 65 have Medicare because that is a Part B reimbursable expense. They just have to bill for it. And that sometimes doesn't happen. And then it is pretty expensive because they are, what did somebody say, up to $40 a shot or something? No, that's a different thing. That's the CD. But they're fairly, I don't know how much they cost right now, but it is an expense. And if you don't get reimbursed, then you're in trouble. Okay, thank you. Let's move into the intersection of COVID and influenza. Erin, if you could get out the next poll, please. You get a call from your DON. Employee A had COVID-19 in March, and now the employee feels sick with a headache, sore throat, nasal congestion, and mild fever. What do you advise? A COVID test, an influenza test, COVID, influenza, and other viral panel testing, or just employee quarantine for 10 days? It's best answer. Let me tell you, that is a real question that was posed to me 3 days ago. And as of information that I got an hour ago, I would actually rewrite this question. All right, let's see what, okay, so the majority of respondents said COVID, influenza, and other viral testing, and some of us say either or one option is to just quarantine the employee for 10 days. So the majority of you have done the multiple tests. And the background for this question is the question, can you distinguish between COVID and other infections, such as influenza, securely and clinically? It's my opinion, and this is backed up by a recent JAMA article, that you probably cannot, although there's those who try to do it. 50% of you said, yes, you should do both tests at the same time. And that is what I would recommend, that we do both tests. We don't do, oh, let's do COVID first, or let's do influenza first, and then do COVID. That's probably not a wise strategy unless you keep people in total precautions and transmission-based precautions. I guess that's always an option. The way I've raised the question, I added the whole viral panel to that, and I'm going to backtrack on that a little bit because I just heard that a complete viral panel is $2,000, and so let's not do that. But what you may get, and what I just heard in the state of Washington is that that most vendors now give you those combined viral tests. So it's going to be probably hard to just get influenza only. You'll probably get always both influenza and COVID, and some may have RSV on top of that, but not, and there may be others who have more, but if you ask for a complete respiratory viral test, it includes human metapneumo and, a lot of other things, and that's $2,000. That's probably not a test we're going to be ordering very frequently, although it does give us information, and you would want to know what your local conditions are in that respect. Susan, how do you plan to handle COVID, flu, RSV if you get it all at the same time? That's our nightmare, and that's what we want to absolutely prevent. Do you have any plans to handle this?
Well, I think you've already discussed some of the testing. Hopefully we will all have received our machines, but then of course we have to worry about the supplies and making sure that we're going to be able to, keep that going to be able to do the testing. But I think, what you've pointed out is the need to be able to be available for both COVID and flu. Because obviously one we do have a treatment intervention for, so we would like to be able to do that, assuming again that we're going to have supply issues. So I think it's that. I think also reminding people the differences a little bit in how we might cohort, and how we're going to manage that when we have our first flu case or our RSV case, and I think all those things are going to be certainly critical. I would say that. There's all of us who are hoping that maybe it won't be so bad this year, because of the fact that we are so much more attuned to infection control. And remember, flu is not as infectious as COVID seems to be. So if we're keeping COVID out of our buildings, hopefully we should be keeping flu out of our buildings.
Yes, hopefully.
So, but yes, I think actually
It's not a strategy.
Yeah, it's not a strategy. Prayer, hope. No, but I think that those are the things that we're trying to do, is make sure that we're prepared with being able to do the testing, quick turnaround time for the testing, making sure we have adequate PPE, all the things that we need to have anyway. The thing that I think will be good, and I've tried to get some of my facilities to do this, and they don't always, is that, you need to prepare, and you need to prepare for flu season every year. And short of ordering the flu vaccine, there's other things that you should be doing to think about how you might manage your whole respiratory illness cycle in the that at least in this country tends to occur in the fall and winter. So that's the plan.
So the component of managing respiratory illnesses, let's say you have a COVID unit and you do get a patient with influenza, how would you handle that?
Well, you don't.
I don't want to put you on the spot. Anybody, but I can also.
You don't want to mix somebody with flu and put them in with a COVID patient. So
Good point.
So I think that's why it is going to become difficult. As it is already, the amount of cohorting we need to do with separate units and trying to keep people separate and safe with just COVID was a problem. But now when you throw flu and other illnesses, and remember RSV is actually probably more contagious than flu is. So, it is going to be difficult, take a lot of time, and that's why it is going to be important to be able to diagnose and confirm these cases quickly.
Yes, I think that is your first strategy of defense to really know what you're dealing with. And in case of influenza, you got treatment. So give treatment if you can. So that's your first strategy, right? Then the second strategy is if you have a COVID unit, you've got the COVID, you are not co-cohorting under any circumstances. But, and then I think you just treat your positive influenza just like you would in any other season. I mean, you have an influenza case on a wing, you shut down that wing, you handle it like you usually would. If there's more than one case, you start prophylaxing the entire unit. If it's spreading through the building, you prophylax the entire facility. All of these things will not change. I think the one thing that might change is, and that's going to be difficult from a supply perspective, and we'll have to see how that unfolds. But I'd like to hear your perspective on this. In the past, and I don't know what you have seen, Barbara or you, Susan, when we had an outbreak and then people came up with similar symptoms, we wouldn't retest. We wouldn't test everybody to the nth degree. So we'd say, okay, we're dealing with an influenza outbreak right now, and symptoms are all over the building. Maybe we do a sporadic confirmation, but we're not everybody getting tested. What do you think in this day and age we should do?
Well, some of it is we have to test because of some of the state reporting requirements. So we do tend to test. I would say in terms of preparing, Susan, I totally agree with you. In many ways, we're all prepared because we're living it.
We already have done that part, yeah.
Where there's limited, if any, activities. If there's, many residents are in their rooms, end of discussion, depending on the facility. I would raise assisted living, but I don't know how much people—
Go ahead, raise it. Raise it.
Because that's a whole different ball game there. Depending on the size of the setting. I mean, some of those facilities have done pretty well, but they are like a home. Some of the staff live there, they stay there. So in many ways, we're already prepared for all the things that we would normally do for flu. They've already been done. I don't know what more we can do besides lock the rooms, because many of these people are so impaired they don't know to stay in their rooms. So we do have those issues and we'll need to continue. But I think we need to test so we know what we're dealing with, particularly this year more than ever, because it's going to be, it already is constant. I mean, I don't know about the rest of you, but the majority of the COVID cases I've diagnosed have been minor. I'm not eating, conjunctivitis, I mean, all kinds of things. They haven't been, as we know in geriatrics, traditional upper respiratory problems. So I think we're there. I think we'll be able to handle that, but we want to test. I also don't believe you don't want to be giving a medication to anybody. There are potential side effects with some of the prophylaxis.
Absolutely.
Patrick may want to address that, but we don't want to jump to conclusions.
Yeah, I always like having a diagnosis before treatment.
Mm-hmm. Yeah.
In general, that's always a good strategy.
What I also think, Sabine, we learned that this theory that, well, if you had one COVID in the building, everything else was COVID, that didn't help us either. Now, granted, a lot of that had to do with the amount of asymptomatic disease that was being spread between both among residents and staff. But I think we have learned that testing does help us manage the problem. And I think this year we probably will be testing more. Yeah. I just, Patrick, curious maybe to talk about the prophylaxis, or whether you're going to change your approach to prophylaxis with Tamiflu if there seems to be cases, and if you perceive that there might be any problems with getting Tamiflu.
Or other options.
Or right, and are the other options really feasible in the nursing home?
Yeah, so really, I have to admit that this discussion has caused me to pull up our own influenza outbreak checklist, and reassuredly, most of it looks pretty good, and sort of laughably, much of it are things that we're just doing routinely now, like was mentioned.
I know.
But I do agree with the statement that we're in a testing world right now, and it does. And I need to think about it more, because I'll admit that I'm kind of caught on the spot thinking about this, but I think we do need to think about how we're using, and how, when is it appropriate to start Tamiflu, given the testing situation, and given the commingling of COVID and influenza. So I need to think about that more, and it's certainly something that deserves more exploration.
Yeah. And in the meantime, I think co-testing, I think it's going to be pretty standard. And I think the vendors have already responded to that. The hope is that we can get the tests when we need them, and that they are then processed in an expedient way. So those will be things that will be unfolding in the coming weeks, I think. Or maybe we won't have an influenza outbreak. I mean, the last one was the pandemic. I mean, the last influenza season was cut short, but that was at the end anyways. So I think, again, that can be, that we hope that that's not a strategy. But yeah, how do we wait for testing? And if it's a combined test, does that affect the resulting of one test versus the other? These are things that I have to probably figure out myself going into the flu season. All right, I think we are getting to the end of the hour. Is there any other comment any of you would like to make?
Just one, Aaron, I know, is kind of spearheading AMDA's efforts in trying to look at getting some tools ready for our members to prepare for the kind of flu/COVID. So hopefully that will be coming and be available for our members sometime in the next few weeks.
Great. Hold on, there's one more question. How do you manage the psychosocial aspect of isolation during this flu COVID season and the next?
That's a whole
That's in the next 6 months.
We keep trying. And
Holiday cheer.
yeah.
Well, I think that pushing forward with visits, as we have, outdoor visits as long as we can, hopefully, and again, it's not a strategy, but hopefully our country will move forward, and we don't have a community prevalence that is high, so that we all get some relief. But otherwise, I think we have all the strategies already in place, and if we don't, we better do that. The televisits, the one-on-ones, all these, the window visits, all that is going to be a little harder in the winter season, but all of these will need to be aggressively pursued, and we'll hopefully have a rich amount of experience to utilize them moving forward. And I don't know that we utilized those in the past when a facility was closed due to influenza. So I think that we have a little bit more tools in our toolbox to do that now. If a facility in fact has been open, which none of them, probably most of them have not been. So thank you very much for participating in this, once again, very informative, lively, but also really, I think I just really enjoyed talking about the human aspects around influenza immunization. I really want to thank you for those contributions. I think we all have learned much. And I think what we have learned that make it law and follow up is probably a good strategy, but you can also work around it and say, make it culture. follow up. Never stop asking and educating. I like that, Barb. Susan, you mentioned the 3 no's. I think that was you who mentioned the 3 no's. Never stop at the first no, and then really tracking where you are at, knowing where you are at, and tracking down the last employee with whatever it takes. I think and removing all the barriers around influenza immunization are proven strategies that will help us this season as well. And I think as far as the commingling of COVID, the unholy commingling of COVID and influenza will hopefully be prevented by those strategies if we it's really not an if, but it's probably a when we encounter respiratory illnesses, we will need to co-test. And then we'll need to use our proven strategies, including treatment for influenza to keep our patients and our employees safe. And with that, I want to thank you again for sharing your expertise, your experience, and your wisdom with us, and taking the time in your packed schedule. I know Dr. Resnick is off to the next talk, I think. And hopefully you'll be able to join us back for our next Grand Rounds in 2 weeks on September 17th. And until then, be well, and thank you for all the work, all the good work, and all the important work and dedication for our patients. Good night. Bye-bye.
Bye.